Hello and welcome to this introduction to IHE-RO, integrating the health enterprise within radiation oncology. So the name of the presentation is Integrating Radiation Oncology, and it's a domain overview and introduction to IHE-RO. I'm Björn Hårdemark. I'm the Deputy CEO at RaySearch Laboratories. I am also the industry co-chair in the planning committee for IHE-RO. So first, an overview of IHE-RO. So the background is that there's multiple complex systems, hardware and software systems that are needed to provide the best care in radiation oncology. And between those systems, information is passed and the boundaries have to be well defined. The better the boundaries are defined, the better care and the better efficiency and the better safety can be achieved. So this is the goal of IHE-RO. The background is that it was founded in 2004 by ASTRO, and since 2007 it is governed by AAPM, the American Association of Physicists in Medicine. And within IHE-RO, it's physicists, physicians, programmers, and others from private practice, academics, and industry that work together to design specifications for how systems should interact to be as safe and efficient as possible. And the aim is to improve the quality and safety of radiation oncology treatments, as well as the efficiency of workflows. IHE-RO is governed by a number of different committees. There's a steering committee that is responsible for leadership of the other committees and also to the connection to the AAPM. There's the planning committee, where I'm the vendor co-chair, as I mentioned. The role of the planning committee is to identify and prioritize use cases that the other, the technical committee then will work on implementing. And the technical committee develops profiles, builds consensus between vendors on how things should be best solved in order to achieve the use cases and the benefits that the planning committee has helped define. The technical committee also organizes the Connectathons, where vendors prove interoperability using the different profiles. So what's this with profiles then, and aren't there standards? Yes, there's a bunch of standards, and IHE-RO uses those. The most commonly used standards are DICOM, which is a standard for exchanging imaging information. There's an extension of DICOM that's called DICOM-RT, and that includes treatment plans for radiation therapy. There's also HL7 and FHIR, which are standards for generic healthcare-related communication. So the standards are used, and the standards broadly define what's possible to communicate. But the profiles that IHE-RO work with, they focus on which specific content should be included and also what the workflow should be. And the profiles define various actors and transactions that are necessary to achieve a use case. So IHE-RO profiles define how the standards are applied, typically by limiting how the standards are used, imposing constraints to focus on the aspects that are necessary for a particular use case. One simple example is that DICOM allows for contours to have any shape and any number of points. They can go on image slices or outside image slices or obliquely or bent, or DICOM doesn't really impose any limitation on what counts as a contour. In radiation oncology, contours are often supposed to be interpreted as building up a solid shape, a 3D structure or a surface. And for this purpose, it's meaningful to only consider planar contours, even only on the image planes, and to have a known limit on the number of points per contour. So this is a thing that can be defined in an IHE-RO profile. And to see if the profiles are working and to be able to show everyone that from the vendor's perspective what the vendors can do and from the users what they can expect, these Connectathons are organized by IHE-RO, and they are cross-vendor, live, supervised, structured test events. And a lot of vendors participate. There's a picture there from one of the more recent ones that were in a physical meeting in Stockholm. And this picture is actually taken by me right after welcoming everybody to the event. The thing with Connectathons is that not only does it prove which profiles work, but also vendors typically send developers that can fix problems in real time or during the evenings and mornings when testing is off. And vendors assume different roles, play different actors, if you will, in these different profiles. So for instance, one vendor can both produce contours and receive contours, or one vendor can be both the oncology information system and the treatment delivery device. And the results are decided by independent judges. And at the end of the Connectathon, there's an official communication on which profiles passed. And no shame on those who participated and did not pass. So the Connectathons are focused on positivity, so only positive results are published. Now, an overview of the radiation oncology domain. As I mentioned, there's a bunch of complicated systems involved. There's actually two screens of them here. First, it's the hospital information system governing everything that's generically clinical inside a hospital. There's the oncology information system that deals specifically with oncology and often with radiation treatment specifically as well, around scheduling of treatments and all the workflows that are necessary. There's also the treatment planning systems that deal with the details of exactly how the treatment is set up. If it's for external beams, it's the parameters for the machines. And similarly for brachytherapy as well, defining dwell points and all the parameters for the delivery systems. There's imaging devices like general CT and PET and MR, and there's also dedicated imaging devices for radiation oncology. Same technologies, but specifically inside the radiation oncology department. And there's the PACS, Picture Archiving and Communication System. That's for storing images in general and also other information. And there are many different devices for quality assurance, and there's also contouring systems. Now, contouring is an activity that can be performed inside the treatment planning system or inside the oncology information system, sometimes inside the PACS or in a separate system. But it's a thing that's provided by many different vendors and systems. Then coming closer to the treatment, there's the treatment session manager and a treatment control system. These are softwares that are in the treatment control room. Sometimes they're blended into one, oftentimes they're from the same vendor. And then there's the treatment delivery device, the actual machine that delivers the radiation. That can be external beams, either with photons, electrons, or protons or other modalities, or it can be brachy. There are in-room imaging systems. And there are patient positioning system. That's most commonly the couch, but it could be other systems as well, a chair or anything else that the patient resides on. And there's motion management systems. Those are for monitoring motions such as breathing and are connected to the other devices during treatment. So here I drew all of these different things as circles and boxes. The boxes are kind of hardwares. The circles are softwares, and this contouring, I put it in a cloud. It can be in the cloud, but it can also be inside one of the surrounding systems, such as the TPS PACS or OIS. So just going through these different acronyms. Oops. There's the hospital information system, oncology information system, quality assurance devices, CT/MR imaging devices, contouring as we talked about, the PACS, treatment planning system. And then there's the treatment session manager, the treatment control system, treatment delivery device, in-room imaging systems, and patient positioning devices. Here, I didn't make a box for motion management systems. They are, to an extent, related to in-room imaging and positioning as well. Now, to go through the different profiles that IHE-RO is working on, I thought I'd put them into context, kind of following a workflow of a single patient. Here, I don't focus so much on the readiness of the profiles, whether they are in a public review or final or just suggested. But this is more an overview of which profiles exist. So the workflow then is kind of following one patient with suspected cancer or with a diagnosis. So there's imaging, and there's registration of imaging, and there's contouring of the target region and also of organs at risk. There's the definition of prescription, and there's treatment planning and preparation for treatment. Quality assurance, the delivery of the actual treatment, and treatment summary in coordination with other hospital resources, and follow-up and potentially retreatment. So first, imaging, registration, contouring, and prescription. This involves the encircled systems here, the imaging devices, OIS, TPS packs, and contouring. And these profiles are basic RT objects interoperability. These are pertaining to images and doses and contour. As I mentioned in the example, those are also, of course, part of radiology, but here the profile defines the content that is necessary for radiation oncology. And this is a content profile. There's multimodality image registration objects for radiation oncology, also a content profile defining how different images should be registered and referring to each other. There's deformable registration object, which deals with registration of images that also have deformation in them, like between different times. If there's one CT image and a later CT image where the patient has changed, it's oftentimes necessary to define exactly how the anatomy changed, and that's then a deformable registration. And there's prescription. There's one profile for prescription in radiation oncology that's surprisingly difficult to have a well-defined and to find consensus. There are different terminology in play here. There's the prescription, there's the treatment intent, and there's the planning directives, and then there's the actual resulting plan, and these are sometimes used differently. Now the treatment planning and the preparation for treatment also involves a couple of profiles. There's the treatment plan content, which has one dedicated profile for photon treatments. There's another profile for brachy and another one for ion treatments. There's the treatment plan imaging content. This is that the treatment plan doesn't only define how the machine parameters should be set for delivering the radiation, but also what imaging should be performed as part of the treatment and as part of the image guidance. And there's also the treatment delivery plan content. This includes other information such as setup instructions and setup images and other information necessary to perform the treatment. Gating instructions are included in that as well. Now, quality assurance is mainly between the OIS that carries has all the information that should be subject to quality assurance, and the QA device. So, and here, this is a workflow profile that's called Basic Quality Assurance Workflow. The idea is to automate the transfers between the OIS and the quality assurance devices, but also to automate the transfer back of the result of the quality assurance. And this is a key aspect, that the quality assurance devices should be able to send an assessment of whichever calculation or measurement they did and a comparison to the treatment plan, to also send that along with the information of whether or not that should be considered a pass or a fail, or if it should be reinvestigated. Now, treatment delivery involves a lot of systems, so here I kind of subdivided it. We have first the treatment delivery workflow. This is mainly between the OIS and the treatment session manager and the treatment control system. This is one of the most tested profiles in Connectathons and involves a lot of different vendors on the OIS and treatment control system side. There's then the more detailed, discrete positioning and delivery workflow. This is between the treatment session manager and treatment control system on the one side, and the actual devices in the treatment room on the other side. So this involves communicating separately with in-room imagers and patient positioning systems and treatment delivery devices. There's the treatment delivery record content. This defines what should be recorded as the result of a treatment. There's one profile for photon treatments and a separate for ion treatments. The delivery record content is, on the one hand, is the delivery passed perfectly, the fraction was completely delivered, or there's various fail states, there's partial delivery, and there's resumption of partials. So those are the most common scenarios. Of course, cancellations as well. And then there is the scenario where the treatment control system and treatment session manager doesn't manage to connect to the OIS or isn't at all connected. For that reason, there's sometimes necessary to tell the OIS manually or offline that the delivery indeed happened and whether or not it was successful. And this profile, treatment delivery offline recording, is for that. And I think it's, it could be seen as a failure whenever it's used, but it's important to have a fallback. Sometimes when networks and systems are down, this has been necessary to do. And then the whole treatment has been done using the previously mentioned profiles, and we're at the treatment summary and coordination phase. This circles here the hospital information system and in the OIS, and the profiles are exchange of radiotherapy summaries. That is including a summary of the most basic information of what dose was delivered, pretty much saying it was 2 gray, 15 fractions of 2 gray delivered to the target site. It could be prostate or liver. It could be more elaborate information, but it's mostly basic information of number of fractions and the magnitude of dose. And here also the abbreviated dose reference comes in. This is a profile for defining kind of conceptual dose delivery that doesn't go into details of the technology used. This can be important to coordinate between different modes of radiation, different modalities such as boron neutron capture that or carbon therapy that doesn't use exactly the same units as other treatments. And then the abbreviated dose reference can be used to summarize the kind of effective dose delivered. This can also potentially be used to coordinate between different OISs if a hospital has more than one OIS. And then there's a follow-up and retreatment. And here we have the radiation oncology history. This is a detailed record of everything that was delivered, not only the superficial level of the previously mentioned profile, but detailed dose distributions, images, everything that's needed for a retreatment or for resuming a treatment that was interrupted elsewhere. So this is when transferring between clinics or when coming back to the same clinic with a previous treatment history. There's a profile for dose compositing, how doses should be added if they have been doses have been delivered on different occasions and using different technologies. Dose compositing does not deal with deformations, but rather with questions around dose grids, resolutions, and rigid registrations. On the other hand, if there was a deformable registration, that can be applied to achieve a deformed dose, which can then be summed up using the dose compositing profile. And then also when following up and within the potential for retreatment comes this question of the ever-growing pile of data that resides within different systems. And to avoid copies and somehow have a chance at managing the increasing amounts of data, there is a profile being defined for query and retrieve in radiation oncology so that images and doses and other information can be stored in only one location and the others can easily search for it and retrieve it from there. So that's an overview of the different profiles that exist. And if all of these profiles, some of them, as I mentioned, they are in clinical use. Some of them have just been defined. Some of them are being worked on. But together they form a really nice mesh of profiles that can keep a clinic running using different systems from different vendors, or also facilitating the transfers between systems of the same vendor. So if you want to get involved with this, and if you're on the clinical side, you can participate in the surveys that we send out to find what new use cases should be defined and how the existing ones should be prioritized. You can also participate in the committee meetings, for instance, the planning committee, to make your voice heard and influence what gets done when. And you can also kind of within IHE-RO, but also separately, just let the vendors know what it is you need for your clinical activities. That's another way to impact what gets done. And I included 2 links here. One is to the top site for IHE-RO, and another one is a wiki with more information on IHE-RO and the different profiles. And you'll find contact information and such in there as well. If you're a vendor, I'd encourage you to become a member of IHE-RO. It's a good way to interact with other vendors in the Connectathons. You can also participate in the committees and make sure that profiles are defined and pursued that suit you. And I included the same links here. So just concluding, I put these words here: fight cancer together. It's I think a good sentiment that industry and academics and clinics have to work together to be as effective as we can in the fight against cancer. Thank you.